You're listening to Aging Uncensored.
All right, good morning and welcome to Aging Uncensored, where we dive deep into all things aging, and nothing is off the books here. You'll see that I am our host today. I'm Shaylee Lawson, and Nicole Crawford joins me as well. Our fearless leader, Christy, is taking a break today from podcasting, but she'll join us again next week. And we have a great topic today. Today we're going to talk about sleep. Sleep in older adults, how that's different, what that looks like, um, and just all things sleep. We all do it. Some of us do it more than others. And sleep changes as we age, and sleep is a major issue for caregivers. And so we're excited to bring some information forward and help you all navigate this.
Yes. So I thought that it would be a good idea today to just talk about like natural sleep things that we can do, sleep hygiene naturally, and things that we can do for ourselves, our kids, our older adults, people living with dementia. And then maybe you could talk about some of the ways that pharmacology goes into that and the things to avoid, what to do, what not to do. Bring that nursing part of it or the medical side into it.
Yeah,
Is that okay with you?
beautiful. Absolutely.
Okay, good. First, what do you do for yourself and your family, and how do you all handle it?
Yeah, I when I was so I know about sleep hygiene, and when I was doing some more research this weekend about it, just to make sure I was on the right page, I really am not the best sleep hygiene person. Now, I certainly do have a routine, and I think that helps my brain like know like you're doing this, it's almost time for bed. Um, but I'm also one of those people who's like blessed with really good sleeping, and I just like hit the pillow and go to sleep, and I never have trouble. Like I sleep 8 hours a week. Like I know that's not normal for most people. So, and of course, like at different times in my life, that's been different for me, you know. But currently in the state I am, with the age my kids are and everything, I'm able to rest pretty well. So, um, with our kids and
That's
our
amazing.
I know, it's a gift. With our kids in our household, we have a pretty good routine. We really try to limit their screen time before bed. And they typically will read until they fall asleep, which I think helps them. Yeah. Um, and I try not to put a lot of pressure. Like we adhere to bedtime, of course, but I try not to put a ton of pressure on an exact time because especially for my oldest child, I feel like it really stresses her out. Like if I'm like, you should be in bed at, you should be asleep at 8:30, and then at 8:31, she's like, I'm not asleep, you know, and it just puts her into this cycle. I think a lot of people do that. Everyone's been guilty of that before, where you're like laying in bed and looking at the clock, and you're like, oh my gosh, I can't sleep. Oh my gosh, I can't sleep. Look at the time. Look at the time. So, what about you?
So
What do you do?
my kids have been curable sleepers from day one. My son likes to stay up late. My daughter likes to wake up early. It's difficult. It's been difficult in the past to get either one of them to fall asleep, either for probably because I was a co-sleeper with both of them. And
Mhm.
yeah, so they both have a hard time falling asleep. My son's gotten better about falling asleep by himself, but we've done all sorts of things like going to bed at the same time. They both take a bath before bed, usually. We have done, there's for children, there's a app called New Horizons Sleep Meditation. It's just
Yeah.
these
Yeah.
little stories with this
Yeah.
English, I guess she's an English lady. And she tells like little stories, and there's little black background music and stuff like that. So we've done that with both of them. Um, for me, like the majority of my sleep hygiene starts earlier in the day. So I wake up around 4:45 to 5 o'clock and either exercise or take the dog for a walk or something. And then I'm up and I've already like really started my day before the kids even wake up. And so I feel like for me, just having that morning time where the sun's coming up and I'm exercising, it helps my body later on in the evening prepare to get ready for sleep later on. So yeah,
Absolutely.
usually I'm asleep generally by 9 o'clock, which as a parent, it doesn't allow for a lot of stuff like doing things around the house or working extra after the kids go to sleep. I'm terrible about that, but I just feel like I have to sleep. So that's what
Yeah,
we
you have to
do.
sleep and doing things around the house. I don't know if it actually lowers your chance of cognitive impairment. So, and good sleep hygiene and adequate sleep does. So,
You're very right.
so it sounds like you have your
Very right.
priorities in check. And
Yeah.
yeah, and like I'm glad you mentioned that about the routine. Like it's very much part of that's your circadian rhythm. You know, your body, and your brain does all of these things, in all of your, organ systems all day long, where your body's very much, on a schedule. Um,
Yeah.
and
Yeah.
so one thing that happens in patients, as we age, and then especially in patients with any kind of neurocognitive disorder, whether that be dementia or if they had a stroke or Parkinson's disease or something similar, is that function is diminished in a sense, and the ability to regulate circadian rhythms is altered. And so
Yes. Yes.
we see sleep issues in a lot of older adults. I know
Go
I know
ahead.
I have, I know you
Yeah.
have.
Yeah.
Um, it's so
When I
problematic for the caregivers also.
It is, it is. And they think that they're doing the right thing by whistleblowing someone who's maybe not sleeping
Mhm.
at night. But I have seen many times over where either their natural pattern was to not get that much sleep, or because of the breakdown in the circadian rhythm, you may have someone, particularly with Alzheimer's type dementia, that will stay awake for 2 or 3 days solid.
Mhm.
And
Yeah.
then they're just wiped out and they will sleep for 2 or 3 days. And it, automatically caused this fear and anxiety among the people that are caring for them because they're not really sure what to do.
Yeah.
So it's hard to educate, especially caregivers working in a community, because it is so important to set up that daily rhythm for everyone.
Mhm.
And so once someone's off of that rhythm, it throws them off of their work rhythm as well.
Ab Absolutely, and some just, like, normal changes in sleep patterns as we age is that there's just less deep sleep, and so
Mhm.
sometimes sleep may feel less restful or may feel like we're easily awakened, and that can also be complicated by things that occur with aging, like urinating more frequently or prostate issues for men or joint pain or inflammatory disorders or all of those things that also may just kind of um, may awaken you in sleep. um, our sleep cycles are shorter. And what I've heard a lot in clinical practice is patients will go to bed earlier, they'll sleep 4 or 5 hours, they'll get up for a period of time, and then they may sleep for a little bit longer. And that's
Yeah.
distressing to people because we were trained by our moms when we were babies that you need to sleep all night long, and a lot of that's a normal pattern, sleep pattern as we age. Like it's very normal.
So,
Um,
yes, to sleep for that 4 or 5 hours and then be up and then maybe sleep for another 3 to 5 hours. Yes, I agree. I've seen
Absolutely.
that over and over again.
Yeah. And as we age, we tend to require less sleep. So everyone's different, but I read this weekend, and I hadn't known this before, that starting at midlife, so let's say 40, every decade after that, you need about 30 minutes less of sleep.
Really?
which I thought was really interesting.
I love my sleep, and I am over 40, and if I can get an optimal 9 hours of sleep every night, it's good for me.
Now,
But
if
and
you're doing that, that's great.
yeah, tell me though if you've noticed this, that as the dementia progresses, particularly in more like later severe, moderate severe stages, your brain is so taxed during those waking hours that you end up sleeping plenty
Absolutely.
more, particularly towards the end of life, where I've noticed a lot of my clients will sleep 18 hours a day because those
Absolutely.
tiny bursts are so exhausting to their brain to try to keep up with the rest of
Um, Absolutely. I would say that, yeah, in patients with advanced dementias or who are close to end of life, or have any kind of really advanced neurodegenerative disease, we see them sleep for long periods of time, and that's very normal. So, um, to sleep 18, 20 hours a day, is not abnormal. We're talking for patients who are, essentially bedbound and dependent for most of their care and, have very, very limited cognitive skills and verbal skills and things like that.
Yeah.
It's not unusual to see those patients sleep a tremendous amount. But kind of in the spectrum of dementia and the trajectory of that, we see in the early stages and middle stages, and maybe even in the earlier part of more advanced dementia, is patients um, may have trouble falling asleep, trouble staying asleep. They may sleep for just very short periods of time. Then they may be awake for 3 days. Then they may sleep for a whole day. And the problem with that, in my perspective, is that it's really a problem for the caregiver. I mean,
Right.
and if I put myself into that caregiver's shoes, like if my kids were doing that or someone I was caring for was doing that, I would be going insane.
Yeah. Yeah. Exactly. And you can't always sleep when they're sleeping like you would on
No,
maternity leave with a baby or something.
no.
Yeah.
Yeah, like, that's such a nice thought, is just sleep when they're sleeping, but we know, like, life goes on, and, like, these caregivers, they have other responsibilities. They may have jobs or children or grandchildren or, they have other responsibilities outside of caregiving. So, for me, when I'm looking at, like, trying to approach treatment for patients with cognitive impairment who also have insomnia or sleep issues, I'm really looking at, like, how can we make this what can we do that's right and safe for the patient, number 1, but number 2, how can we make this caregiver's life a little bit easier?
Yeah. Yeah. 100%.
Yep.
Do you ever recommend, like, if families can do shifts in a sense, like, so that people can get rest, good rest away from the person that they're caring for?
Absolutely. I mean, absolutely, that's wonderful when that can happen, and in good, healthy family dynamics, that does happen, but I would say oftentimes what we see is we see an individual caring for a patient independently without a whole lot of support,
Yeah.
whether it just doesn't exist or whether they don't feel like they can ask for that kind of level of support. And so I do think anytime, and I'll say this, like if I tell caregivers too, if a patient is waking up at 3 a.m., but they're okay. They just lay there or they watch TV or they're not like disrupting the household. Like
Yeah.
we don't have to do anything about that. Like that's okay. That's normal.
Yeah. Yeah.
If they're disrupting the household and you know no one else is getting sleep because of that, then we may need to alter our approach. But otherwise, like we can just educate these caregivers on how sleep patterns change and what's normal as we age and with cognitive impairment. Um, I don't love just throwing uphill, especially to help someone sleep,
Yeah.
there are absolutely times when that's necessary and I do it. But there's so many more things that I think we can try to do first.
Mhm. Mhm. So one
And
thing I recommend, and we had a client that did this very beautifully. And
Mhm.
I explained it to him. I drew a picture. I do this for a lot of families. It's basically like a bell curve. So start off the morning and increase your sunshine, increase the light in the house, increase the noise level, increase the activities, and then you kind of arc it around 2, 3, 4 o'clock, and then start bringing it back down.
Yeah.
And decreasing sunshine, decreasing the artificial light and the noise, and like have a general rhythm that kind of flows into more of a sleep pattern, and make sure that there's sunlight in the morning and in the afternoon so that you feel like your body sees the sun coming up, sees the sun going down. And then if you can throw in activities such as adult day programs or
Mhm.
some sort of exercise during that kind of arc, I think that it makes the body a lot easier to transition into a sleep pattern later on in the evening.
Absolutely. I love that. And like that just helps to kind of regulate that circadian rhythm when an aging or demented brain is not able um to control the circadian rhythm, then they really rely on external factors way more than like you or I do.
Yeah.
So all of those external things that you just mentioned are so important. Um, Light is so important. I mean, I remember this patient I took care of years ago, who had a lovely family that cared very well for her, but she spent a large majority of her day in the basement.
Oh.
And it was like a finished basement, that was kind of her
Mhm.
space.
It
But
wasn't like a creepy crawly
no, no,
basement
no,
with
no,
like
no, no, not like that.
water dripping.
No, no, it was a lovely basement, finished basement, but it just like, basements tend to be darker, like, there's less light, there's less windows, and as a result of that, she was spending a lot of time in the dark. And
Mhm.
she was napping a lot during the day,
Yeah.
and the family, was there with her at night, but they had to work during the day, and so it was very distressing to them because she was up and, in the nighttime, and so we were able to, like, just make some adjustments with lighting, and it took time. It wasn't like we did it one day and it was, like, fixed. Like, it's gonna take some time.
Yeah.
Made some adjustments with lighting and opened some windows and did what we could with what we had, and it did help things.
Have you
Um,
ever prescribed like UV lighting or the blue lighting or whatever the special light bulbs are? Have you ever done that with any of your patients?
oh, I haven't done it so much, but I know I'm familiar with what you're talking about, or like the blocking lenses and like
Yes.
the
Yeah.
idea about the kind of blue light
Mhm.
disrupting sleep patterns and things like that.
Yeah. Yeah.
Um, No, I haven't done that. That's something that I should think more about.
I think
Um,
where we are in Alabama, it's easier to get like natural daylight. Uh,
mhm.
but I'm thinking basements or maybe higher areas that don't get as much of that kind of daily
Yeah.
sunshine, or places that don't, 6 months of the year dark or things like that. I know that
Well,
that's
and patients in facilities too.
that's true. Yeah. Yeah.
Um,
It makes a huge difference.
Huge difference. Just a little bit of sunshine.
Yep. So, what are some safer medicines and what are some medicines to avoid if that is the route that needs to be taken with yourself or with a loved one that you might be caring for?
Yeah, so one medicine, if anyone's heard of it, called Benadryl.
that
Or
is that's a bad word in our
it is
industry.
a
This
really bad word in the geriatrics. So Benadryl, and it's also called diphenhydramine,
it's
and
called what? Say that one more time.
diphenhydramine,
Diphenhydramine.
and it is an antihistamine and a medication that blocks acetylcholine. So we'll come back to that piece, but it is in a lot of over-the-counter sleep aids. Like Tylenol PM is Tylenol and Benadryl. Advil PM is Advil and Benadryl. Z-Quil is Benadryl. Anything that you buy that says sleep aid, chances are it's Benadryl, diphenhydramine, or it's a similar medication in the same class. So,
So let me just hit a little time out there.
yeah.
If you're on a medicine for memory,
Mhm.
well, the ones that we have now, not the newer ones, but the older drugs, those are ones that boost acetylcholine in the brain,
Mhm.
right?
That's
And
right.
then you throw a Benadryl, which blocks
Block it.
acetylcholine
Yep.
at night. So that just sounds like a terrible chemical warfare in
It
your brain.
is. It is. It's
Oh,
it's terrible. So acetylcholine is a chemical in your brain that helps with a lot of things throughout your body. It helps with muscle contraction and coordination. It helps with memory. It helps with coordination and learning. And what we'll see is that patients who are not even just patients with dementia, but aging patients in general. So, I mean, I would probably argue that anyone over the age of 60 should not be taking these medications.
yes.
Um, they just your body cannot tolerate it like you can when you're a younger person.
Mhm.
So what happens is it blocks the acetylcholine and it increases the fall risk. Um, it can increase behaviors in dementia like agitation and delirium. It can um, make them much more confused. And I've seen this many times. Like, I'll go and see a patient, they had a fall overnight. I'll ask them about any over the counter medications, and they'll say, well, I take a Tylenol PM every night. I have for the last 10 years. Um, and you could have taken it for 10 years and nothing happens until it does. And
Yeah.
so I think being really open minded and understanding that as we age and our physiology ages and the way our brain reacts to medications like is not the same over time and we have to do things differently.
Yeah.
But I always stop those medications. I mean, I think people have this kind of sense that if something's over the counter, it's often benign and it must be safe.
Right. And you can
Um,
take double because it's not prescription strength.
and I mean, I think we're all guilty of that. I know I am myself sometimes, but the thing is that just because something is over the counter does not mean it's safe, and you need to be having a conversation with your healthcare provider,
Yeah.
about whether that medication and like you said, is it interacting with, you know, a lot of the medications that we give for dementia, um, chemical warfare. I love how you said that in our brain there. So,
Yeah.
please, 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 if you don't do anything else, please just avoid Benadryl and any over-the-counter sleep aids. Read the label, ask somebody, just please.
So what are
Um,
your thoughts on things like melatonin or magnesium
yeah,
or what about those?
I'm okay with those. So if you melatonin is fine. I find that it has somewhat limited effectiveness. It tends to help with falling asleep, but
Mhm.
generally well tolerated and not a huge side effect, not a side effect profile like Benadryl. So I'm fine with people taking melatonin. Um, I would just say I think like up to 10 milligrams is what I would recommend.
Mhm.
Probably wouldn't recommend more than that. I think you just have to be mindful about, you know, it's a supplement and any supplement is not going to be controlled. So you want to make sure you're getting a good quality supplement.
Oh, yeah, that makes
Um,
sense. Mhm. Do
yeah,
you have a
and
time frame? Because I've told most family members anywhere from 2 to 4 hours before bedtime.
yeah, I think probably up to 2 hours would be good, is what I would recommend. Um, yeah, yeah. And I think
Good.
if you want to know, I mean, you can always ask your pharmacist. If you've got a good pharmacist, ask them if they have a recommendation about, you know, a melatonin supplement that you can purchase over the counter.
Mhm.
I would argue that they're not all created equally, and you really need a good quality supplement if you can get one.
Yeah, yeah, I agree. I agree. So what else? I know that a lot of our people are on trazodone.
Yeah, so trazodone is an old medication. It's an antidepressant. It works pretty well for insomnia. it is a good medication to reach for when you've got patients with cognitive impairment who have, sleep disorder, like sleep dysfunction that is affecting them and affecting the caregiver. The thing about trazodone, I always tell patients it has a pretty wide um, dosage range, and so we kind of have to work till we get to the sweet spot. For some
Yeah.
people, the sweet spot is 25 milligrams, and for some, it's 200. And so I just tell people not to give up on it until, like, I'm like, if it's not helping, call me, we'll increase it. It's generally well tolerated. There's not a huge side effect profile. The majority of patients are not groggy the next day. They
I
can
was
like
going to ask, like, what's the half-life for that? Do you know?
I don't know off the top of my head. I don't know off the top of my head, but it's you know what? Let's look and see.
Let's look and see. Too bad we don't have Taylor Crane with us today, who could be some fact checking.
Let's look and see because I was looking at some other medications this weekend and curious about their half-life. So
Yeah, I
okay,
know we talked
so the half-life is 3 to 6 hours, which
Oh,
is
okay, that's
right.
great.
Yeah,
Yeah.
so essentially that means for those of you out there that about 50% of the drug has left your system at that point, at the half-life point. So, um, so it's not long. Like a lot of other medications that are used for sleep are much longer. So I think that's generally why it's well tolerated.
So tell me this, because and not being a non-clinician, and then I'm jumping medicine subjects here. People say that Seroquel has a very short half-life. I find that it builds up in the person's system over time. It may take weeks, it may take longer than that, but I find that the people who take Seroquel on a regular basis tend to just be less sleepy, or excuse me, more sleepy, less mobile, less animated over time. Do you see that, or do you totally disagree?
Yeah, so Seroquel does have a shorter half-life. And in order to be dosed effectively, it has to be given at pretty frequent intervals in order to get the full effect of it. Um, yeah, I do see over time, I think patients who need antipsychotics, and that's a completely different ballgame. Like I do see over time that they reap the benefits of them, with more consecutive use. I don't use antipsychotics for sleep. Um, I feel that they're not always super sedating. Patients tend the
Everybody's
spectrum of
different.
everybody's different. The spectrum of that is really variable. And antipsychotics are really helpful medications when they're needed. But they have a side effect profile, and you've really got to outweigh the risk and make sure that the benefit outweighs the risk when it comes to those. And for me as a clinician, for sleep alone, it just
Yeah.
doesn't work for me. Um, it's not good medicine, I don't think, to prescribe those for sleep alone.
Which I have seen it done before.
I have too, and there's always an exception to that. So I'm not saying anything about the bad about those medications, but I think it's like a conversation that needs to be had between the caregiver, the family, the patient, the provider about what the risks of those medications are. What are we trying to get out of the medication? And do those things align? And does it make sense to use it? Because there are times when it does, but it's definitely not something I reach for sleep alone.
Yeah. Yeah. So what are some of the other ones that you looked at this weekend?
So mirtazapine is one that we use a lot. Um, and it is also an antidepressant. Now, these are different than SSRIs or SNRIs. So these can be taken with other antidepressants, like if you're on Zoloft or Prozac or more kind of what we think of in general world as traditional antidepressants. Um, so mirtazapine is a great drug I use actually pretty frequently. In lower doses,
That's what I was gonna say. It's a low dose, isn't it?
yeah, in lower doses, it's a little bit more sedating. It also helps with appetite as a side effect, and it helps with sleep as a side effect.
Yeah.
Generally, I think the research has shown that it doesn't help with just sleep alone without there being some aspect of depression. Um, but I feel like I feel like that's not really hard to find in aging adults who are facing a lot of uncertainty and functional dependence and all of those things. So generally, I use it a lot. I think it's really effective. It um, it doesn't have a huge side effect profile. It's generally really well tolerated. And another thing that I didn't mention is both of these medicines are inexpensive.
Yeah,
So,
that's great.
they're inexpensive, which is a huge factor. I would argue that they may even be cheaper than Benadryl over the counter. So,
So, okay, is mirtazapine is another name for Remeron?
yeah, it is. Yep.
That's
That's
what I thought. Okay.
yeah.
So I've seen it given for anxiety, for increased appetite, and when those things are done, I generally will ask or steer the clinician to say what time of day should it be taken, because sometimes there's not that given ahead of time, and I've seen people take it first thing in the morning.
Correct.
Mhm.
Yep. No, absolutely. Yeah, and it always needs to be dosed in the evening. Now, higher doses of Remeron can be more stimulating, so your provider may change the dosage of that in the morning, but generally, lower doses of Remeron need to be dosed in the evening.
I see. So what happens with the higher doses? Do they eventually get sleepy when it gets to a lower dose, or they just it works as a stimulant at that point?
I think the way that medication works, it works, yeah, just more as a stimulant at that point. Um, so I rarely prescribe higher doses, so usually 7.5 or 15. But if
Mhm.
we're gonna go up to 30 or 45, then I would dose that in the morning.
Yeah. How do you feel about some of the other prescription medicines?
So, a few others. So we have the hypnotics that are not benzodiazepines, but that's your Ambien. Lunesta is another one.
Belsomra.
Yep, yep. Um, those medications are tricky, so they work well, but they are habit forming, meaning that over time you'll require that to sleep. Um, and then they come with a black box warning of complex sleep behaviors, meaning like sleepwalking. People have been known to operate motor vehicles while they're like in this sleep awake state. And so there's a lot of danger associated with that.
Mhm.
Those are not typically medications that I prescribe. They're definitely not medications I would prescribe first. I think they're definitely there's a use for them, but they really like the benefit needs to outweigh the risk, and the all the factors need to be considered.
Do you think that that is for someone who's younger or someone who has more psychiatric issues, not for your general granny who's 85 and, slightly off her, a little bit with her cognition?
No, it's really that's just not a great medication for older adults. Period.
Okay. Yeah.
It would not be one that I would recommend. I would want to avoid that if I
Mhm.
could.
Good. Good.
Yeah. And then you have your other benzodiazepines. So those are like, benzodiazepines are like Xanax and Ativan, which those can be used for sleep. Sometimes they have a pretty short half life. So they kind of work quickly and then they're out of your system quickly. But more commonly, benzodiazepine wise, I see temazepam used.
Mhm.
It's has a long half life. It's very long acting, as well as Valium.
Mhm.
A lot of times, what happens is that those patients were started on those medications years and years ago. Like they've been on temazepam for 30 years, for
Yeah.
40 years. And as we age and our physiology changes, the way we metabolize medications changes, Like, just because you've been on something for 30 or 40 years does not mean that it's still safe for you.
Right.
So, it always warrants a conversation about discontinuation, and those medications really have to be weaned when they've been on them for a long time. Habit forming, um, they're not fun to stop abruptly and can be quite dangerous actually, so it's not anything you ever wanna stop abruptly. Um, but I think in general, we really try to avoid those medications in older adults unless it's just absolutely necessary. I don't see it prescribed so much new for older adults, but what I see is a continuation of something they've been on for years and years.
For a long time. Yeah. And I think the same is true, not just for sleep aids, but just for all medicines in general as someone ages. I've seen people not need blood pressure medicines anymore that they've been on for 30 plus years, or, like Lipitor, or just any number of medicines just don't necessarily, they're not needed at that point.
Absolutely. And I would say any good primary care provider, internal medicine provider is really going to be looking at your medications, especially for someone like a provider you see long term. Like,
Mhm.
they need to be having conversations with you about, is this medication still necessary? Why are we still on it? Are you having side effects now that even though you've been on it for 10, and if they're not, like, I would empower families and caregivers and patients to, you know, comb through your medication list with fine tooth comb with your provider and ask them questions about it.
And usually your annual appointment, there's more time set aside to do those sorts of things. So, like just a little annual review, bring your list of medicines and just go over with your doctor. If you can't remember why you're taking it, it's maybe a good indication that you may not need it,
Absolutely.
or that you've been taking it for so long that it really needs some evaluation to see if you need
Absolutely.
it. Mm, yeah.
Absolutely. And that's a good opportunity. Like, if there's not enough time in a regular appointment, then to make a follow-up telemedicine appointment or follow-up appointment with the APP or whomever. There may be other opportunities. So yeah, just think about pills you're swallowing and talk to your
Mhm.
doctor about them
Mhm.
or
I know
provider.
I talk to the pharmacist too. A lot of times, they're good at like, because you have different providers. And if you don't have, the quarterback of providers, your general primary physician that does all of that, just like talking with your pharmacist and saying, hey, of all my medicines, is there anything that's doing the same thing? Is there anything that,
Mhm.
is not working well together? And they're good at
Mhm.
being able to tell you that as well.
Yeah, absolutely.
So, what are some other things that we could do? I know I've got like a list of stuff here,
Yeah.
uh, different things that are better than medicine.
So another thing I failed to mention previously about sleep hygiene is limiting, well, caffeine, number one.
Yep.
Caffeine has a pretty long half-life, so no caffeine after lunchtime if you're having trouble sleeping. Um, and that's something that I need to change myself. I'm not very good at that.
That 2 p.m. mark in the day where it's like,
That's
if you're going to make it through the evening, especially have little kids or someone else to care for when you get home, like you might need a little something,
you need a little boost.
little
Um,
boost.
so but I think for older adults in general, like really limiting their caffeine. I don't have a problem with caffeine in the morning for older adults. But after lunchtime, I would say no more caffeine.
Yeah.
Um, and then alcohol, and this goes for anybody, is that alcohol is not a sleep aid.
A lot of people don't realize this, that
Yeah.
as your body is processing the alcohol and the kind of more sedating effects and the effects that you feel when you're first drinking it start to wear off, your body kicks in to
Yeah.
this state of anxiety, and it actually will wake you up at a certain time. And it's a
Yeah.
stimulant.
So it can be, and then as your body just processes the alcohol and which turns to sugar as you process it, like, you
Mhm.
will wake up in the middle of the night, like, you cannot sleep well. Now, when you're 20, you may drink a lot and sleep really well, but when you if that ends in your 20s, it's gone abruptly. So, so really like limiting any alcohol, I would say even, you know, 4 hours before bed, 2 to 4 hours at minimum, is really going to be helpful. Um, and then, medications, there are medications that we take routinely that are stimulating. And so I think just always it goes back to like having a conversation with your healthcare provider about timing of medications. Specifically the some of the medications that we use for dementia, so the acetylcholinesterase inhibitors, so that's like the donepezil, galantamine. They can have a side effect of bad dreams or just vivid
Yes.
dreams. And
Yes.
so, and of course, like that can affect someone's sleep greatly. Um,
Mhm.
and so timing of those medications, like if something has changed and in your sleep patterns, like look back at medications.
Yeah, yeah. I've had several clients that we have talked with their providers about changing those medicines to morning time or changing things like Zoloft to nighttime
Mhm.
just to kind of, help the sleepiness, help the bad dreams, trim it all even. I have a client that she was having crazy, strange dreams and then kind of like being in a certain state where she would wake up and see like shadows and things like that. So she started
Oh.
limiting her tramadol for pain, for back
Oh.
pain and things. So
Oh,
yeah.
yeah, that can be really distressing. And, when I think about that, like when I think about vivid dreams too, and we haven't really touched on this, but about sleep disorders. So,
Mhm.
like obstructive sleep apnea, um, restless leg syndrome is pretty common among older adults. And we won't dive deep into those today, but those are just something to, like keep top of mind for providers and then just to have a conversation with your providers about those things as well. They certainly affect your quality of sleep and your ability to sleep and all of those things.
And it may not be something that you feel like it's worth calling your provider or maybe getting on the portal, but I would say definitely write that stuff down and just have a list
Mhm.
ready for when you do have your next follow up appointment 6 or months or so later so that you can address those things.
Yep, absolutely. Totally
Mm.
agree with that.
Have you ever asked people to do yoga, meditation, like music, limiting sleep in the daytime?
Yeah, yeah, absolutely. Limiting sleep in the daytime is a big one. So not napping. I sometimes I'll see patients and they'll nap a lot during the day and then they can't sleep at night, which makes sense.
Yeah.
Um, and then things like meditation or like winding down. I mean, even if it's not formal meditation, but people may have other rituals like prayer rituals or, journaling or like something that's not stimulating,
Yeah.
you know. Um, I think just really limit it. Like people, oh gosh, watching the news before bed. Please don't watch the news before
Uh,
bed.
so, yeah. I actually did that and, well, read the news on my phone Saturday night, and it took a little bit because I went to bed angry.
Yeah. So just, like really limit activities that are going to be stimulating and just really try to give your brain some space to wind down.
Yeah. Yeah. And this is something I hadn't even thought about until recently, but having pets makes a huge difference. Like my
Yeah.
dog and cat have their own sleep wake cycles and patterns and things. And so I've gotten to the point now where our puppy or our dog, there's nights when I just need a break and she gets put in her little kennel and she wakes up when I tell her to. Otherwise, she's up at 2 or 3 a.m. trying to go outside. The cat's up at 4. So it can be difficult. So lock up your pets.
That's a good point. Yeah, I have an old dog who is like very happy to sleep 20 hours a day. So, but yeah, no, that's a good point. That's a great point.
Well, before we wrap up, I'm going to tell you my favorite. It's not a sleep story, but it's related. I was at a facility visiting one of my clients, and another person who was living there. I probably told you this story. she was asking for more coffee. It was mid-morning-ish, like 10:30 or so. And so I went up to one of the people that were in the kitchen, and I was like, this person would really like some more coffee. And they were like, no, she can't have it. And I was like, well, that's not very nice. So I went and got a cup, and those little 4-ounce styrofoam cups. And I gave it to her, and they were like, Nicole, she has had, that'll be her 5th cup of coffee. Well, I mean, it's little 4 ounces, but still her 5th. And so I set it down in front of her, and her name was Ida Joe. And I was like, Ida Joe, instead of calling you Ida Joe after this cup of coffee, I'm going to call you Jittery Joe. And she looked at me with this deadpan straight face, and she said, and I'm going to tell you to go to hell.
That's amazing. Hey, do not mess with people in coffee. Come on now.
No, I agree.
Switching to decaf if you have to. Drinking coffee. It's okay for older adults or for any adult to drink decaf coffee all day long. It's absolutely fine.
Well, and I find that I had one person that lived at St. Martin's. She was a night shift nurse. She was a head nurse at a hospital.
Yeah.
And so at 5 o'clock, starting 5 o'clock, she was on it. She wanted to know where the coffee pot was. She wanted to know if it was fresh, if it was full. She wanted a cup. And so that was just part of her lifelong pattern. And we definitely would give her decaf coffee at night.
Yeah, that's a huge thing to take into consideration is like, what have their patterns been in lifetime, and like, what was their, what did they do for work? What was their lifestyle like? Were they a cross-country truck driver who had really alternate schedules all the time? Were they a night shift nurse? Like, what were they doing? Like, is this a new problem, or have they been alive 85 years and never slept all night? So those are things you would want to consider in, your approach to helping these people.
And if you are the person moving your relative living with dementia into a facility, I always recommend doing like a biohistory so that everyone has the same information.
I love that.
My grandmother did XYZ her whole life. This was what time she went to bed. This is what time she woke up. This is, generally her daily pattern and her likes and dislikes. It's going to change as people, are in a community, and I'm going to be the person eating all the cheeseburgers one day. Someone puts me into a facility. So it will change, but at least it gives the people that are there a frame of reference to go by and to start with. And then if they do revert back to those things, then it's like, oh, light bulb, she never slept at night.
That's right. That's right. Exactly. Yep.
All right. Well, thank you, Jaylee. You've been a most wonderful host.
Thank you, Nicole.
With the
It's been a pleasure as always, and we hope that this has brought some insight and advice to those who may be struggling with sleep, or their loved one is struggling with sleep. And
if you remember nothing from this podcast, remember, don't take Benadryl.
Please don't. Please not doing it.
All right. Thank you so much, Jaylee.
All right. Bye. Thank you.
Bye.